Hello, everyone, and welcome to today's Phlebotomy Webinar on impact of pre-analytical variables on clinical laboratory testing and patient care. This is Janice Berquist, an education specialist for Mayo Clinic Laboratories. Our presenter today is Dr. Brooke Katzman, an assistant professor of laboratory medicine and pathology in the Department of Laboratory Medicine and Pathology at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the Q&A icon on Zoom. Please only use the chat function for any technical issues. Today's program is being recorded and will be posted to our website in a few weeks. And now I will turn things over to our presenter.
Well, thank you, Janice, and welcome everyone. Good morning or afternoon, wherever you're logging in from. So today we're going to tackle a fairly broad topic, and this may be a bit ambitious, but we're going to cover some of the pre-analytical variables that are important in laboratory medicine, phlebotomy, and I've really tried to narrow the scope substantially to cover the most common aspects that are encountered in lab medicine. To begin, I do not have any financial disclosures related to this talk, and I will not be discussing any off-label uses of medication or devices. So what we're really going to focus in on are the pre-analytic variables that are most commonly associated with unacceptable blood specimens that are collected primarily in the hospital environment. Next, we're going to discuss how often we encounter these pre-analytic factors that result in specimen rejection. And then finally, I'll share some effective strategies to reduce specimen rejection rates and ultimately mitigate the risk of patient harm. So when we begin to start thinking about the concept of pre-analytic variables, it's often described in the context of pre-analytical errors. And so in general, an error is defined as the failure of planned action to be completed as intended or using a wrong plan to achieve an aim occurring at any part of the laboratory cycle, from ordering examinations to reporting results and appropriately interpreting and reacting to them. And according to the National Academy Institute of Medicine errors, the Academy of Institute of Medicine, errors are actually responsible for nearly 100,000 deaths and upwards to 1 million injuries each year in the United States. So this is obviously very important and something that we take to heart. And just to put this into context, this is a graph shown here that relates the number of fatal deaths that occur each year per 1,000 exposures to various activities. And so what you can see along the x-axis is a spectrum of whether it's very unsafe or very safe. And it's really not surprising that we have shown here Mount Everest, climbing Mount Everest at the very top for the number of fatalities and the most unsafe activity. However, what you find quite surprising is to see the number of fatalities that are associated with several of these medical interventions. We have Whipple procedure, labor, colonoscopy. And I don't share this necessarily to scare, all expectant mothers and those receiving these treatments, but I really wanted to show this simply to say that we can do better, we should do better, and we really do need to improve patient safety in order to change this type of graph that I have. And we know that patient safety is not only important in the hospital for the types of procedures that I had described on that last slide, but we know that it is also critical in laboratory medicine, as we know that nearly 70% of all medical decisions are based off of the results obtained from laboratory testing. But it's important to take a step back and understand how patient safety can be highlighted within what is called the total testing process. And this is where it both begins and ends with the needs of the patient. This is a multi-step process that begins with the patient and a clinical question regarding that patient. It's followed up by a physician order for a laboratory test. Then that patient undergoes preparation procedures and a specimen is collected, which is then sent to the lab for specimen processing and then eventually analysis. That report result is then reported into the patient's record. And then finally, the physician interprets that laboratory result and can manage patient care. And so you can imagine that this process can happen, many different times in the care of a patient's particular episode. And of all these steps that they really do fall into what defined phases. So we have the pre-analytical phase, the analytical phase, or the post-analytical. And within this entire process, what I'm hoping to show is that phlebotomists essentially serve as the face of the lab, interfacing with both the clinical practice, the patient, and the testing laboratory. And so hopefully by the end of this talk, you will see how phlebotomy plays a crucial role in delivering accurate and timely results to better care for that patient. So when we think about where this process tends to break down, we know that the pre-analytical phase is responsible for about 46 to 68% of testing errors. That's followed by the post-analytical phase, accounting for 19 to 40% of testing errors. And then finally, the analytical phase, accounting for approximately 7 to 13% of all testing errors. And so what I have shown here in the pre-analytical phase, these are just some of the most common causes for pre-analytical errors. And we'll go through several of these. The first is inappropriate test request, order entry errors, misidentification of patient, an inappropriate container or specimen collection type, sample collection and transport inadequate, inadequate sample or anticoagulant volume ratio, insufficient sample volume, sorting and routing errors, and labeling errors. And so we can go on and on about the number of possible errors within the testing process, specifically within the pre-analytical phase, but these are just some of the more common ones that we encounter. So why are these pre-analytical errors such a problem? Well, the issue is that they create bottlenecks throughout the course of the testing process. And unfortunately, we have different mechanisms to detect some of these problems and even solutions, but all of these options lead to delayed results and ultimately can delay appropriate care for the patient. So if the problem of specimen integrity, we can often detect that using automated serum indices, specifically on the analyzer, or we have rules that help us detect these in our lab information systems. And then the solution would be there's a delay result, that patient may have to be redrawn, or we may have to manually treat specimens. Another problem, if not enough specimen is collected, again, this can be detected up front on our analytics system or within the analytics system itself. And again, patient may be redrawn and delayed results. So you can kind of see, yes, we can detect these, but ultimately this does cause a delay. And so we want to try to avoid these up front. So what I have listed in this table are some of the bottlenecks that we incur at Mayo Clinic, specifically in our ED. So one of the metrics we evaluate is the number of recollections and reasons for those recollections. And so these data are from January to April of this year. And you can see that hemolysis is the single highest cause for specimen recollection, accounting for about 75% of all ED recollections. Next, this is followed by clotted specimens with approximately 11% of reason for recollections. And then we have both QNS and suspected specimen contamination that have very similar percentages of 2.7 and 2.5% respectively. So throughout the rest of the presentation, we'll discuss each of these pre-analytical variables in detail. So as I mentioned, hemolysis accounts for the greatest number of specimen recollections, and not only among the ED practice, but really the rest of the inpatient hospital practice as well. And I would say that it's pretty safe to say that hemolysis is the most common pre-analytical variable encountered at most, if not all hospitals, likely including your own. And so what exactly is hemolysis? So this is defined as the rupturing or lysis of red blood cells and the release of their contents, usually the cytoplasm and free hemoglobin, into the surrounding fluid, which in this case was plasma. And this can really occur in two different routes. This can happen in vivo or inside the body. And these are usually physiologic processes or disease states like hemolytic anemia, or this can happen in vitro outside of the body. And those are some of the cases that we're going to discuss. So essentially a collection issue that results in hemolysis. testing. And so we have to be aware of what problem and how do we address those. And so I like to show, from a testing perspective, garbage in really does equal garbage out. We want to make sure that we have the best specimen we can collect so that we provide the most accurate results possible. So often the question we get is how much free hemoglobin is needed to generate a testing interference? And like most answers in medicine, it depends. So first, it depends on the test. All tests are not created equal when we're considering sensitivity to hemolysis. And the mechanism of interference can actually be a result of an analytical interference. So this is the inability of the instrument to measure the analyte of interest in the presence of hemolysis. Or it could be a physiologic interference where the concentration of the analyte within the red blood cell is much higher. And so when you have hemolysis, you're essentially dumping all of that analyte into the serum. And so it would likely represent a false increase in a serum concentration. And this is particularly the case with potassium, AST, and lactate dehydrogenase. And as I mentioned, some tests are more sensitive to hemolysis than others. So, the ones that we're concerned about, especially from the ED perspective, is potassium, AST, LDH, direct bilirubin, and then even troponin. Troponin T can be quite sensitive. And so these are of concern because they're obviously needed in a very timely manner, and you need accurate results when a patient arrives to the ED or is in the ICU. And so we really have to consider these tests when worrying about hemolysis. And then the next depends on the lab. So most labs will follow test manufacturer guidelines. So manufacturers in their instructions provide a cutoff for how much hemolysis is acceptable and above which the results may be compromised. However, and some labs will release results with a comment. Some labs will recollect specimens. There are other labs, and we have labs at Mayo where we often do some experiments to define our own hemolysis interference thresholds. And so we've validated these and used these. And often we do this to try to raise the threshold that shows that it's not going to impact patient results. So as far as detection of free hemoglobin, we use an instrument, the use of instrument automation helps in this process to detect and then handle specimen integrity issues. So it provides assessment of sample quality by really two possible methods. And ultimately, you're measuring an arbitrary index. So you'll often hear the phrase serum indices. These are units or arbitrary units or a conversion that can be used to approximate the milligrams per deciliter of hemoglobin. So it's typically a 1-to-1. So in this schematic, it shows the possible location of those serum indices on an automation line. The pre-analytical automation systems may actually have cameras that are located between the centrifuge and the aliquoting section, so shown right here where you have that optical detection. And essentially how it works is it takes a photo of that sample and then using system software, it compares it to the appearance of the current sample with representative photos that are previously designated by the user. Really serves as a form of calibration for the qualitative optical assessment. But more commonly, automated serum indices that reside actually within the chemistry analyzers themselves. And these indices are often based on absorbance measurements at two different wavelengths. And so it's whether it's in the pre-analytic stage or the actual analytic stage shown here. So as I mentioned, serum indices exist essentially as a test on the chemistry module of an automated system. So these indices are semi-quantitative, and an onboard calculation is used to convert the absorbance measurements into the units of hemolysis or icterus or lipemia, whatever interference you're evaluating. And hemolysis or icterus indices can be expressed as arbitrary index units or converted, again, as I mentioned, to the estimated milligrams per deciliter of either hemoglobin or bilirubin. And then the lipemic index is really an assessment of turbidity. And so it does show a poor correlation, however, with triglyceride concentrations. So it's important to note, though, that while these measurements demonstrate decent precision, and obvious there are advantages over subjective visual inspection, most laboratories do not routinely QC those serum indices, and so they really should not be used to correct results. So when we think about how does it impact testing, well, potassium is the analyte that we traditionally use to teach students and illustrate the impact that hemolysis can have on laboratory tests. So because of the concentration gradient between intracellular and extracellular potassium, significant elevations in potassium can result from rather modest levels of hemolysis. And so this graph shows the relationship between the hemolysis index and the concentration of potassium in a homolysate spiking experiment. And so in our laboratory, we use a hemolysis index comparable to about 100 milligrams per deciliter hemoglobin. That is the rejection threshold for potassium. So samples with this extent of hemolysis would then be recollected. And so if you look at the hemolysis chart at the top of the slide, you can imagine that it would be a bit challenging to consistently differentiate between 100 and 200 milligrams per deciliter hemoglobin, or between 250 and 500 milligrams per deciliter hemoglobin. So the use of that automated analyzer is very helpful in these cases. And as I mentioned, most institutes have moved toward use of these over visual inspection. All right, so when we look at the causes of specimen hemolysis, we often think the first thing we think of is drawing from an intravenous or IV start or central line. And so how much higher is hemolysis from an IV start compared to venipuncture? Well, depending on the study, it can be anywhere between 2 and 5 times higher in IV starts. So for example, if your standard hemolysis rate is 3%, it could be anywhere from 6 to 30% higher for an IV start. And as I mentioned, it really depends on what your starting venipuncture rate of hemolysis is. And from literature and our own experience, it suggests that approximately 5 to 8% of samples are hemolyzed. So shown here, this is a systematic review of emergency department practices for reducing hemolysis in blood samples that are sent to the clinical laboratory for testing. And this is a meta-analysis. So all 11 studies comparing new straight needle venipuncture with IV starts found a reduction in the hemolysis rate. And so use of a new straight needle venipuncture instead of IV starts is really effective at reducing hemolysis rates in the EDs. And this is really recommended as the evidence-based best practice. So this example clearly shows that we need continuous improvement with automation, and not to forget the contributions in the pre-analytic testing areas. So some of these, some hints include working closely with collection areas to get the sample you need. Try to be careful of workarounds that pop up, and focus on identifying and solving the root cause. So as far as the rate of hemolyzed specimens, when we ask the question, what is the lowest rate of hemolyzed samples that you would get from the ED, NICU, which is obviously typically the most challenging draws, when a sample collection is optimized. So that means less than 10% IV start draws in the ED, really focusing on the rate of blood withdrawal and sample type processing in the NICU. And we find that 2 to 3% in both environments is achievable. IV starts are more problematic than central venous or arterial lines. And so we found that training can improve the hemolysis rate with line draws below 5%, but there's really no good evidence that this can happen with IV starts. And literature suggests the prevalence of hemolysis in overall routine samples is as high as 3.3% and up to 30% in the ED. So we really try to be cognizant of how those samples are collected. And one of the benchmarks that's been identified is the American Society of Clinical Pathology that defines an acceptable or an ideal rate of hemolysis as a less than 2% of all collections. So that's sort of the mark that we strive for. So what about the NICU? These hemolysis rates are usually reported anywhere between 2 and 10%. And in these cases, venipuncture is often not an option. They have catheters and indwelling lines because they're difficult sticks. And so there are several important factors related to these hemolysis rates. The first is serum versus plasma, whether or not that patient is having a lipid emulsion administered, how that sample is transported. Is it transported using a pneumatic tube system? And then also, as I mentioned, the rate of withdrawal from the arterial or venous line. So how do we know these factors are important? Well, we performed a study at Mayo several years ago now where we looked at all of these variables, and we were able to reduce the hemolysis rate from 6 to 4% by attempting to avoid our AM or routine draws during a time when lipid emulsions were being administered. And also by retraining nurses to slowly withdraw blood. And so all of this got us down to about a 4% hemolysis rate. Since that time, we have switched from a mixture of serum and plasma testing to all plasma testing. And for our very low birth weight infants, these are often the most problematic patient population, we've switched to bedside point of care testing. So those two additional measures that we've adopted since this study have allowed us to stay at around a 2 to 3% hemolysis rate. So other causes of hemolysis. So we've talked about some of the other major interventions we implemented to reduce our hemolysis rate in the ED and NICU, but there are others that some of the questions submitted wanted to hear about. So historically, data suggests that collecting with small gauge butterfly needles increases hemolysis. And this is actually a very controversial area right now. We do have one of the vendors has reconfigured their butterfly needles with the goal of minimizing hemolysis. So it's a thinner wall of a butterfly needle, so there's no change in the overall size of the 25 gauge butterfly. This allows for a bore size for 25 gauge to equal that of the previously 23 gauge butterfly. They have multiple beveling to decrease pain, and the vendor suggests that fill time and hemolysis rate are similar to 23 gauge butterfly needles, and our data actually support that conclusion. So as a result, butterfly needles really no longer are a concern for increasing hemolysis, according to our data, again, with this particular manufacturer. And accordingly, the CLSI has updated their guidelines to say the use of some, that's the key word there, 25 gauge needles increases the risk of hemolysis and rejected specimens. And so here are some data from a pediatric study where we looked at the 21, 23, and 25 gauge butterfly needles. And you can see that the number of samples is relatively low. But if you look at the mean hemolysis index, it actually went up from 21 gauge to 23 gauge, and then back down again at 25 gauge. So if you look at the 25 gauge needle, the mean free hemoglobin is essentially the same as a 21 gauge. So now we're at the point with newer technology where we don't really know how much of a factor the use of the 23 or the 25 gauge butterflies are. And again, it's really important to realize in this PED study, they were done in the appropriate infant. So we were using a 25 gauge butterfly with an infant that has very small veins. So it's still matching needle size to vein size. So, if you were to use a 25 gauge with an adult, you would likely still have hemolysis. So that component doesn't change. And so I have listed here, these are just some of the other contributing factors of hemolysis. So, prolonged tourniquet time, ideally you want that on there less than a minute or less. So what is the possible consequence? Well, you get hemoconcentration. This obviously affects water balance of cells, causing rupture of those red blood cells. And so obviously the corrective action is to release the tourniquet as soon as blood flow is established in the first tube as possible. Next is cleansing procedure with isopropyl alcohol. If venipuncture is performed before alcohol is allowed to dry, this can cause red cells to rupture. And so obviously the solution is to allow alcohol to dry thoroughly before collection. The next is needle placement. So vein trauma can result when needle placement is not accurate. And so it's really important that we keep that needle parallel to the vein and then reposition the needle forward and backward, avoiding probing. The next is vigorous mixing of tubes. So this can cause red blood cells to rupture, and obviously solution here is to gently invert the specimen the appropriate number of times. And then finally, tube choice. So a tube vacuum might cause blood to enter the tube very forcefully. So this can cause cell rupture. And so if it's a partial draw tube is not acceptable. So in the cases of, coagulation testing, there may actually be smaller tubes that are available. So we've reached the end of the hemolysis topic, and the other of these are a bit shorter. So moving on to the other variables, as we saw, they tend to be much lower than hemolysis. So in this case, clotted samples is the #2 cause of rejected specimens. So CBC specimens for complete blood cell counts are collected in EDTA, and then we have coagulation testing that's collected in citrated plasma. And so if these specimens clot before testing, they are unacceptable. And so most labs will have a visual process to assess this before they test the specimen. Some more advanced instruments will actually have this detection within the instrument. And what we know from clotting is that it tends to happen on larger orders, often in infants and children. This is, where you have more tubes to fill. So we actually looked at training and a 2-tech system. So 1 tech to draw and then 1 tech to mix that specimen quickly via inversions. And unfortunately, we really couldn't support this model. So unfortunately, really no magic bullet at this point, but we do perform direct observations and continue to stress the importance of gentle inversion. And really, this is the only thing that we found to help. And so we also monitor the number of clotted specimens that are obtained. All right, the next variable is QNS, or quantity not sufficient, where the name suggests. So this is essentially not enough to test the specimen, or the specimen does not contain the correct ratio of blood and anticoagulant, and that's particularly important in coagulation testing. So this is most commonly encountered in the NICU due to several reasons. So the first is these babies tend to have an elevated hematocrit, which essentially means a reduced plasma volume, and it can be as high as 70% in a newborn. And so it's not until approximately 3 months of age that that hematocrit will normalize to an adult value of around 45%. And the next, and I would say probably the bigger challenge that we deal with, is obviously blood conservation efforts. So these are, really important. We want to reduce the high rate of hospital-acquired anemia, stated in the literature to be anywhere between 41%. And so the recommendations, as you may know, less than 3% total body volume for a patient that's less than 2 months. And so this equates to approximately 9 mils per day in a 7-pound infant, and then less than 10% total body volume for patients that are older than 2 months. And this is, about 150 mils per day for a healthy adult. So, we're really trying to limit the amount of blood collected from these babies. And as a result, we often end up with specimens that are just not enough for testing. So most analyzers actually don't require a significant volume of plasma or serum for the actual test or reaction itself. But it depends on a couple factors. The first is the sum of the individual test volumes. So for example, a comprehensive metabolic panel, this requires only about 50 microliters of specimen. So, approximately 15 tests, you can accomplish that with about 50 microliters of plasma or serum. But it's the dead volume that often ends up being the issue. So this is the volume of specimen that remains after what was sampled for testing. And this can be, anywhere between, 250 to 300 microliters of specimen that are required in order to be able to accurately sample that specimen. And then, as I mentioned, we also have the indices for specimen integrity, checking for hemolysis, lipemia, and icterus. And this really only uses about 10 microliters of specimen. So to reduce the QNS among our NICU patients, we provide a list of commonly ordered tests and the minimum volume required so that testing can be prioritized. So if they only obtain a certain amount of specimen, what tests do they absolutely need, and how can we get that performed? All right, so the next area we'll discuss is line draws, as this really relates to the sample contamination, which is our 4th highest reason for rejected specimens in the hospital environment. Really doesn't apply much to outpatients because those line collections are fairly limited to certain patient populations. But we know there are a lot of issues with line draws. They can cause hemolysis by taking the blood out of the line too quickly, usually with a syringe. It can dilute the blood with IV solutions, so the concentration of everything that's measured would be affected. And then we can also obtain the drug that we're trying to measure. So for therapeutic drug monitoring or heparin, anti-10A or APTT, the heparin that's in that line, it can cause an interference essentially. You'd be measuring that drug in the line versus the systemic drug, and this can cause for very high elevations. And this is probably the most dangerous of the scenarios that can happen, where we think that there's a much higher concentration of drug on board, and so we may withdraw or reduce. That obviously can have some consequences there. So if we have so many problems with line draws, why do we do so many in the hospital? And there are really various reasons for this. The first is nurses trying to protect patients. So, trying to promote that patient comfort. The next would be burden. So most practices, nurses draw from lines, and in many practices, a lab person will do venipuncture. So to provide a more timely medication monitoring, it's probably more timely to access a line than wait for someone trained in venipuncture to get there and collect that blood. And then finally, these patients are very sick. They're in the ICU or the ED. And so once venous access is obtained with the catheter, the intention is really to use that for collections. And so all of this contributes to potential for contamination. So in accordance, the CLSI guidelines from 2017 on the collection of diagnostic venous blood specimens state that collecting blood from an arm that is being infused with IV fluids carries a potential risk for erroneous and misleading results. And so ultimately, they recommend using the opposite arm wherever possible. We know that this is not always going to happen and isn't possible. So when it's not possible, the recommendation is to collect distally or below the IV site, where you're discontinuing IV fluids for approximately 2 minutes. You're flushing that line with anywhere between 5 and 10 cc's of saline. You're discarding 2 times the dead volume. So that dead volume is the distance from the end of the catheter and the patient and the port you're trying to dry that sample. So 2 times the dead volume for non-coagulation testing and 6 times the dead volume for coagulation testing. And usually 5 cc's is sufficient in these cases. And importantly, do not draw drug levels, and this includes heparin monitoring, from lines used to infuse the same drug. And so we're very similar to the guidelines. We definitely do discontinue when possible, and the phlebotomist will often note that for the lab. We perform a 10 cc saline flush for adults. We discard about 5 cc's of blood for adults, and this will vary. So if dextrose or total parenteral nutrition is being given through the lumen used to collect, then we'll waste about 10 to 20 cc's before collection. But if you're measuring something like glucose, then 20 cc's is preferred, because just a small amount of glucose hanging in the line is enough to cause a result to be falsely elevated. And then we require a 10 cc minimum for coagulation testing. And then we prefer Vacutainer if the adapter is available and the line is drawing freely over the syringe. So we know there are a number of problems associated with line draws. We know we can get hemolyzed specimens, but we can also get contamination resulting in various analyte patterns depending on the infusion being administered. So we can get falsely elevated results, for example, glucose, magnesium, phosphorus, calcium, potassium, sodium if saline is being administered, or chloride, and then falsely decreased. So creatinine, hemoglobin or cell count, sodium, and this could be an example where you have a dextrose infusion where sodium is less than 50% of the amount of serum, and then also, again, potassium. So our experience is that PICC lines are actually overrepresented among contaminated specimens, but we now have more dual lumen PICC lines, so this is really less of an issue. But in the past, there were only single lines, so you had to be giving some sort of solution through the same line that you were collecting through, whereas central venous catheters often have multiple lumens. We know that draws from patients with intravenous nutrition are problematic, so that lipid emulsion or total parenteral nutrition in particular. And so if we can avoid that, we're better off. And then patients getting magnesium or calcium or phosphorus replacement can be problematic, so we try to coordinate timing with administration to collection. So many years ago, we did a study in both hospitals, our St. Mary's and Methodist hospitals, asking the question, if we knew we were pausing the infusion and doing the correct waste, would there be contamination? So we sent people out to observe and found that they were paused for 2 minutes or nothing was being infused. And so we had no contaminated specimens at the Methodist Hospital. So about 541 line draws and no contaminated specimens. And the same was true for St. Mary's. So about 149 line draws were documented. The appropriate discard or none was depending on what was being infused, and 0 contaminated specimens. So we think we can avoid contamination if you do the 2-minute pause at the proper discard, avoiding TPN or patients receiving those calcium, magnesium, phosphorus infusions. And so if you do a few simple things like that, and again, it's obviously easier said than done. It's usually out of the control of the lab. So by making people aware, we can try to limit this issue. And so ultimately, it's a nursing decision to discontinue. So if we give TPN or dextrose or a drug, we're not going to use the same lumen for collection, and then ask if the discard comes easy, then we would use that vacutainer versus the syringe for the actual blood draw. One deviation for this procedure is the collection of blood culture tubes. So for these collections, we do not flush the lines or discard any blood volume. And remember that for venipuncture, vacutainers are not to be used per CLSI guidelines. TPN is actually overrepresented in our contamination. So this is nutritional support. It's given intravenously, compounded for each individual patient. So it's really hard to know exactly what is in each solution. So this is an example shown. It's not universal, but it's just an example. You can see has a very high glucose of 15,000 milligrams per deciliter, very low sodium of 41 millimole per liter, where you would expect then a false decrease in sodium if there was contamination. Very high potassium, so when normal is 4 to 5 millimole per liter, this is 16. And then a very high calcium of 30 milligrams per deciliter, and then some other vitamins, minerals, and amino acids. So therefore, one or more signs of contamination would be an increased glucose, an increased potassium, an increased calcium, and then potentially a decreased sodium. But we need to remember that there are a lot of other things in TPN that can affect testing. So, we need to think about other analytes that we often don't think about, such as insulin or vitamin measurements, because those too can be impacted. And then another area I'll touch on relates to contamination, but order of draw, which is also quite controversial. So this was opinion paper looked at all the literature and postulated 3 potential mechanisms of incorrect order of draw. So you can have hypernatremia due to sodium citrate or sodium EDTA, hyperkalemia due to potassium EDTA, hypocalcemia, low magnesium, zinc, iron, or alkaline phosphatase due to that potassium EDTA, kind of chelating those metals. Poor coagulation due to transfer of anticoagulants. You can have clot activator transfer that interferes with coag tests, and then also dilutional effects from pouring one sample into the other. And so this is one of the rare situations where we have a CLSI guideline, but we also have this European Federation for Clinical Chemistry Working Group, which did an extensive review and had consensus conference on a number of pre-analytical phases or pre-analytical questions about blood collection. So the European Federation went over 3 potential mechanisms for anticoagulant contamination for potassium EDTA contamination of syrup tubes when the order of draw is not followed. So whether it's direct transfer or pour off. And again, obviously, if you need serum and you collect potassium EDTA and you pour into that serum tube, then you're going to have a contaminated specimen. This is obviously a very bad practice, and we don't expect to see that where we have trained phlebotomists. The next would be backflow during a closed loop or a vacutainer collection. So if you snap the potassium EDTA tube onto the vacutainer adapter, there is a potential for some blood that has potassium EDTA on it to stick to that adapter, and that could get transferred into the next serum tube. And we're going to show you in a minute or so that the studies really don't suggest that actually happens with the lyophilized or the solid potassium EDTA. And this is what may have changed going to these plastic tubes where you have that lyophilized reagent or anticoagulant. So we really don't see that there's carryover from backflow on a Vacutainer adapter. And then the next mechanism is contamination by a syringe. So if you use a syringe to dose the tubes in the incorrect order, so for example, dosing the potassium EDTA first, then the serum, there is the potential to carry over some of that potassium EDTA from the purple top EDTA tube to the serum tube. And data on this, whether it really happens and how often it happens, is also somewhat spotty and controversial, but really that is what we're going to talk about next. So these studies are the ones that were cited in the European Federation Working Group document. So this was one study of 11 healthy volunteers drawn by an experienced phlebotomist. And in this experiment, they drew a serum tube, a potassium EDTA tube, and then a second serum tube to try to measure in a healthy outpatient if there was any measurable EDTA carried over from the middle tube into the second serum tube. And the answer is actually no. So EDTA was not detectable in any of the serum samples when looking at the measurements that would be affected by potassium EDTA contamination. So obviously, there was no excess potassium detected. And then the metals like calcium, magnesium, and zinc, where we would expect those to chelate to EDTA and be falsely reduced. And then also the enzyme like alkaline phosphatase that needs calcium and magnesium for those reactions were also not reduced. So there's no difference between the serum tube before the EDTA and the serum tube drawn after. So this was really a small study of 11 healthy volunteers, but it really didn't find that contamination occurred when you drew an EDTA tube before a serum tube. So this is another study. This is a larger one evaluating the order of draw and the need for a discard for coagulation among 100 outpatients that were visiting the coag clinic. In this study, there was really just a different order of collection. So they were looking for a potential carryover of one anticoagulant to another tube, and again, found no difference in the PTT value or time. And so they concluded that there was really no significant carryover. And so 2 studies now that we have show that backflow contamination doesn't happen or it's uncommon. So there's really no evidence of backflow contamination where potassium EDTA sticks to the Vacutainer adapter and then contaminates a serum or plasma specimen collected next. So then you may conclude that, for routine Vacutainer collection, that order of draw really makes no difference. However, there is evidence in at least some UK hospitals. So again, that you can select for some, so when they selected for unusual findings, so very high or very low potassium or very low calcium, you can find that around 1 to 5% of these cases in most studies are caused by EDTA contamination. So it does seem to happen, and this is very consistent with our own experience and practice at Mayo. So we've discussed the 3 phases of the testing process and how any one of those phases can result in a testing error. However, the data suggests that the pre-analytical phase is really the most susceptible to these errors. And one of those errors can result from hemolysis. And this is true for both inpatients and outpatients, but today I focused on the inpatients. The practice of drawing blood with an IV start, usually in the ED, the best you can really hope for hemolysis rate with these line draws is 5 to 8%. And so if you avoid IV starts, you can typically achieve somewhere between 2 and 3%, which is consistent with the benchmark recommendations. If you can discontinue infusion for 2 minutes, you have that 5 cc discard at a minimum, and you find some ways to deal with your heavy hitters like that magnesium, calcium, or even those drugs, so collecting at appropriate times, you can dramatically reduce contamination. And then finally, I reviewed data from the potassium EDTA from incorrect order of draw. And the answer seems to be yes, this is possible. It really happens primarily in the inpatient environment where syringes are utilized, but it's really not that much of a problem for the outpatient where a Vacutainer is primarily used. So with that, I'd like to thank you all for attending the webinar, and I would be happy to entertain any questions you may have.
Thank you, Dr. Katzman. At this time, we would like to take any questions that you may have. If you would like to ask a question, please be sure to select the Q&A icon on Zoom to submit your questions online.
So the question that came across is, did you say not to flush or waste when doing cultures? Our practice is that we don't flush and we don't waste. So you don't want to flush because you don't want to basically clear out any bacteria that you're actually trying to measure. And then by wasting, you can have, surface skin bacteria, things like that interfere. So that is our practice. And I believe that is consistent with CLSI guidelines. There were some other questions that I received earlier, and so I can try to go through some of those while others may have questions. So the first question was how to minimize hemolysis from a line draw with extension tubing. And so I have to be honest, we actually don't use extension tubing. But in general, I can state that you'd imagine the same recommendation that, drawing slowly, drawing with minimal force, you're still going to have potential with the, because it is a line draw, but really trying to focus on the rate of withdrawal and that force should help with that. The next is, and this is a tough question. So how do we deal with poor samples? So from a lab perspective, I can give you kind of how we handle this, and this all feeds back to our phlebotomist. So depending on the sample integrity, we will reject these specimens. And I'd argue that this is actually best practice. But we know that that's not going to always be necessary, or that result actually may be needed. And so how do we handle that in those scenarios? So we really, in these cases, we kind of weigh the risks of reporting. So, what type of analyte could we be reporting? How much might that specimen integrity impact the result? Could it change from a normal result to elevated and cause some downstream impact? So all of these things we consider, and then we can have a conversation with the provider to discuss all of this. So one example I can think of is when we have known cases of intravascular hemolysis. So this is a hemolytic anemia or a patient that just came out of cardiovascular surgery. They're shearing red blood cells. This is not a collection issue. We may report some of those analytes. So for example, potassium, this truly does represent the concentration in circulation in that particular context. And so we would report those results with a comment describing it. And I would say that with regard to the comments themselves, we have to be very careful. We don't like to use blanket statements that this result may be inaccurate, consider with caution. What that does, that's a problem, because it really doesn't arm the physician with much information on what to do with that result. And it also ultimately tends to result in a distrust of the lab, So I think the best we can do is when we are going to report potentially impacted results, we try to explain the direction of the interference. So is it going to be falsely decreased or falsely increased? And then if we have this information based on manufacturer's inserts or studies we've done, we talk about the magnitude of difference we may expect. So for example, potassium may be falsely increased by 30%. So that provides the information to the physician to say, this is what we may expect to see. We provided this result, and just consider this when you're dealing with the patient, and look at the clinical signs and symptoms when considering. All right, so I'm gonna, let's see. There's some other questions coming through. What about line draws utilizing the push-pull method after the flush instead of discarding? This is used for our most frequent blood draws when the patient is anemic. Has Mayo done any studies? That's an interesting question. I am not familiar of any studies we've done. I guess it really depends. The only study I can think of is with some of the sticky antibiotics. So tacrolimus or cyclosporin. Those drugs, we have found that they are very hydrophobic. So they stick to that plastic line very well. And so we've done flush studies with those to say, will that actually get flushed from the line? Is there any amount of, flush of saline we can use that will clear it? And the answer is it requires quite a bit. So that antibiotic stays in that line for quite a while. And so because of that, we've actually had to have dedicated lumens to just those drugs. So it's marked, it says, tacrolimus or cyclosporin, and the phlebotomists know not to draw from any of those lines. But the push-pull method, I don't know that we have any data on that, but it is an interesting concept. I guess the question would be, if you're pushing the saline back in, the problem would be that now all of that surrounding area is sort of diluted with that saline. So you may have some of those dilutional effects that I described, but I guess, yeah, we would need to see if any of those studies show that. All right. Let's see. When a patient needs an HSV swab or any swab, is it only done by the provider and RN, or can the patient do it themselves? This is interesting. I don't believe, the only tests I can think of where we allow, and I could be wrong on this because this isn't necessarily my area, but the only area I really think that we do this with is actually for like saliva cortisol. I think for viral, viral testing, that we do have specific protocols where, a nurse or a provider or someone is actually doing the swab to make sure that it's you're getting a good amount of that specimen on there. So I don't know that we actually do that practice. All right. Another question that I received was, what pre-analytic errors were the rarest during blood draws and the most damaging to the results? This is a tough one. This is very tough because often if it's rare, we don't always have a way to detect it or find that from when it happens. I would say, and this is kind of an obvious one, but specimen mix-up, surprisingly not fairly rare. We can have this happen if you're pre-printing labels and you're pre-labeling specimens prior to completion of that draw. So specimen mix-up can be an issue, and I would say that would be very important for the example when there's a type and screen. So you're going to have the potential for some transfusion reactions if you happen to switch, one patient with another, which is why we do type and screen twice. But that is one of the examples I can think of where it's a challenge, and often those are really hard to trace back unless it's, we're collecting a CSF specimen for glucose or total protein measurement, and it looks like it was collected on Mr. Smith, but Mr. Smith was never in for a lumbar puncture. So that we try to troubleshoot and go backward, but those can be hard to trace down and can, as you imagine, really result in some pretty damaging results. The next question, when drawing coags, what is the time that you have the IV turned off when we have to draw on the same arm as the IV running heparin? So in this case, we still do a 2-minute pause, and we've found that works. So if you pause it for 2 minutes and you've cleared out that line, that is important and can be useful to reduce any particular contamination, because let's say you're grabbing some extra heparin in the line. Now your PTT and your AP or your PT may be prolonged. So we still do the 2-minute delay, or I guess having it turned off. Another question I received, and I kind of touched on this, but I'll talk a bit more about it, is how do we ensure ER staff is collecting optimal amount of blood to minimize turnaround time? So we talked about this in the Q&S section. We've had this issue with the NICU because of blood conservation efforts. So I'm not really sure from an ER perspective, it's a little surprising that you wouldn't have enough blood unless you're, dealing with peds patients, but usually they're pretty good about it, at least at our institution, but the NICU is where we have those challenges because of that blood conservation. And as I mentioned, what we've done to really address this is provide that list of minimum specimen volumes, particularly for the tests of interest. So if your ED, really needs a potassium or, excuse me, several other basic metabolic parameters, providing them with the volume that's needed. That way, when they draw that, they can prioritize which testing they need according to the amount of specimen collected. But it's important to mention, incorporating not only the specimen volume for the actual testing itself, but also, any dead volume that would be required. So working with the lab on that, I think, is really helpful to provide a list for them so it's known up front what's needed. And another question, this one relates to lactic acid draw on patients with no visible or palpable veins without using a tourniquet. So how do we handle this? Well, obviously it's recommended to draw lactic acid without a tourniquet, but this also can be done immediately after applying the tourniquet. So if the tourniquet is applied for an extended period of time, in that case, you would want to remove the tourniquet and let that blood circulate 2 minutes prior to redrawing or retrying the collection. And so we collect those in a gray top tube. But this is actually kind of controversial. So there are some studies that have shown there's really no impact on lactic acid measurement, and others have found that the tourniquet can lead to a false increase. So I would say, if you really do need to use that tourniquet, try to draw immediately after it. And if it's applied for too long, greater than a minute or so, remove that, let that blood circulate for, another 2 minutes, and then go ahead and retry. There's another question, and I don't know that I'm the best person to answer this, but the question was, is it possible to collapse a vein? When you draw with a syringe with a butterfly, the blood just stops. Why would it do that and there's no hematoma? Yeah, that's a good question. I don't know how often we encounter that, but don't have a great answer for that. I don't know if it's perfusion, if it's a poor perfusion, somebody that's in shock or something like that, but I don't know that we encounter that so often. So I apologize, I don't have a best answer for that.
Well, I think we're out of questions. So thank you everyone for participating in today's phlebotomy webinar. If you have any additional questions, please indicate them on the evaluation that will be forwarded to you tomorrow. Please note, laboratory credit is extended for this program. Upon finalizing your evaluation, you will have an option to claim credit and print a certificate. As a reminder, this program was recorded and will be archived on our website in a few weeks. Please visit the education website for more information on upcoming education offerings and the list of upcoming phlebotomy webinars. Our next phlebotomy webinar will be on August 18th, 2021 from 11 a.m. to 12 p.m. and the topic will be transition from skin test to IGRA. Thank you again for joining us for today's webinar and have a great day.